Welcome everyone to our head and neck Rover session. I'm Archie Pallam. We have Emma Fields, Jenna Khan on, who will be helping our resident moderate today, JP Obaid, and then Nav is on as well, our coordinator. So maybe we can just get started with having the panelists introduce themselves before we go on to the cases. Oh, and then a few housekeeping things before we get started. As we go through the cases, this is meant to be interactive, so please put any questions that you have that you want to discuss in the chat box and make sure it's directed to all panelists and attendees so everyone can see the questions and our responses. We'll also have some poll questions throughout the session that you can participate in. Okay, so let's get started with intros. And then we can start with Dr. Wilkie and maybe introduce yourselves and say a few words on why you went into rad-onc.
Sure, absolutely. So my name is Chris Wilkie. I'm an assistant professor here at the University of Minnesota. I specialize in head, neck, and brain tumors. And as far as why radiation oncology, so my background is actually in imaging, and as a biomedical engineer for both undergrad and then I did combined MD PhD program. And so coming out of medical school, I was thinking radiology, and I didn't really know much about radiation oncology whatsoever, which I think is sort of a common theme among a lot of staff. And I did a radiology rotation. I like the interventional part of it, just from the patient interaction, but I really missed that when I was just in the reading room itself. And by fortuitous chance, a couple of my colleagues who are a couple of years older than me in the MD PhD program both matched radiation oncology that year. So I found out a little bit more about the field, learned that you get to use pretty awesome tools and physics to cure cancer, and signed up and have been loving it ever since.
Great, and Dr. Jillian Tsai from Memorial is going to be joining a few minutes late, so let's go to Dr. Hinson.
Hello, I'm Christina Hinson. I'm an assistant professor at the University of Oklahoma, and I am our residency program director. And I went into rad-onc. I kind of knew going into medical school that I wanted to do something with oncology. That's why I went to medical school. So it was just a matter of narrowing it down. And I really, really liked gyn-onc when I did that rotation and thought about that, but I'm not a surgeon in my heart. So rad-onc for me was a good mix of procedures and clinic and some radiology and of course the cancer patients. So I just really like kind of the variety in what we do.
Hey everyone, I'm JP, PGY5 here at Stanford. So I'll be helping moderate this session as we go through it. So I guess we can get started. So we'll go through, hopefully, we put 3 cases in here, but we'll see how far we get. So for case 1, we have a 65-year-old gentleman with a past medical history significant for prior renal cell carcinoma, status post left radical nephrectomy. Now notice the right painless neck mass while shaving. So he monitored it for a bit, seemed to be growing over the past 4 to 6 weeks. So he ended up coming in. And basically, we would just ask to please describe what would you look for on H&P of this sort of presentation. So we could start with Dr. Henson.
Okay, so we see a man with a history of 1 smoking-related cancer, renal cell carcinoma. So I'm definitely going to want to get a good social history, find out about a tobacco history and alcohol history and things like that. On physical exam, really going to want to take a good look inside of his mouth, inside of his nasopharynx, inside of his oropharynx and his throat. So ideally a scope exam to look for a primary, because what we know is that, you know, a painless neck mass is often going to be an airway cancer, an aerodigestive tract cancer. So that's what I'll be looking at.
Yeah, exactly. So he ended up getting an NPL, or a nasopharyngeal laryngoscopy. And we see the following sort of pointed to by the orange arrow sign, but perhaps, Dr. Wilkie, you can walk us through like what you generally see in this area.
Sure. So we're looking at a flexible nasopharyngoscopy, and you see, as sort of nicely delineated by the arrow, you have a little bit of asymmetric fullness within that tongue base there. Yep, exactly where your pointer is at. And then looking at the rest, some other techniques you can do is have the patient stick their tongue out, vocalize like E, and take a good look at the vallecula. And then also take a look into the supraglottic and glottic structures too, which on this exam you don't really see too much. But the next thing I'd want to do is do a digital examination and sort of feel around that base of tongue. And like completely echo what Dr. Henson said earlier is you really want to do a really detailed head and neck physical examination on these patients.
Okay, so we'll start with our first poll question, which is what do you think you would do next?
While the poll is going, Dr. Sai has joined us.
Hi, everyone. Sorry for being late. Thank you for having me here.
Okay, so can we see the results here? Okay, so it seems no one wants to, or sorry, one person wants to give antibiotics, which actually we do see a lot of patients come in with in head and neck clinics. So it's not necessarily a wrong answer, but most people want to do an FNA. So perhaps we can talk about briefly the different kinds of biopsies and what would be most accessible for a neck mass.
So an FNA biopsy is like an aspirate of the lymph node. So it's just a hollow needle where whoever's doing it is just aspirating a small section of the tumor. And that's usually adequate for these types of tumors. Excisional biopsies are where the entire lymph node would be removed. An incisional biopsy is where part of the mass would be removed. Usually those are not recommended unless we're more suspicious for something like lymphoma. Don't know if anyone else has anything to add.
Yeah, I completely agree. And FNA is usually nice too because it can be performed in clinic.
Yeah, exactly. So that's what this patient ended up getting. And so when the pathology read came back, the diagnosis was compatible with an extensively necrotic squamous cell carcinoma. And they ran a P16 testing on it, which came back positive for it. So maybe we can ask Dr. Sai, what do you think of this P16 testing, and sort of what does this mean in the context of like a base of tongue cancer?
Yeah, so I think right now, can you guys hear me okay? So right now, P16 testing or HPV testing has become more like a routine, especially for oropharyngeal cancer, because we know that patients with HPV associated oropharyngeal cancer tend to have a different disease trajectory and tend to have a better prognosis compared to P16 negative or HPV negative oropharyngeal cancer patients. And this may help us dictate the route of the treatment and recommendation. So right now it's becoming a routine to test for these in the setting of oropharyngeal cancer.
Yeah, exactly. So maybe a little bit of a harder one, but we'll give it a shot. What do you guys think this scan in series represents?
Maybe while everyone's putting in the poll, one of the panelists can explain MRI and the different sequences. Dr. Wilkie.
Sure. So MRI, there's the T1 and T2 weighted sequences correspond to the relaxation. In this case, what we're usually measuring with MRI is looking at water molecules or hydrogen, but specifically hydrogen bound to oxygen and water. You can look at other molecules too, and that's usually with high field sequences, and that would bore you all to death. But predominantly what we use for clinically, at least in the head and neck, as well as CNS tumors, is looking at the T1 versus T2 and then with and without contrast. And an easy way to tell just T1 versus T2 is look at fluid signals. So in this case, I think JP can sort of, yep, exactly. So you see the CSF here is bright and then that cord is dark. And so that automatically tells us that this is a T2 weighted sequence.
Great, thank you. So they ended up getting this MRI of the neck as well as a PET scan. So the MRI showed what we saw, which this part really is a complex cystic nodal conglomerate in the right level 2 neck, measuring 3 by 2.3 by 4.3 cms, consistent with a cystic metastatic node. And at least on the MR, they didn't find the primary tumor site. So we ended up getting a PET for both primary delineation and systemic staging, and they saw the same thing more or less. So they saw the level 2 stations being involved, but also they said the primary tumor site was not identified and there was no evidence of distant mets. So maybe we can have Dr. Henson just kind of like tell us what you see on these scans or what you would look for in a patient with this sort of cancer.
Sure. And I'm just going to add something for the few people who said that they would have started with a PET scan. That wasn't necessarily wrong. You're just not usually going to get a PET scan approved until you have a cancer diagnosis. So that's why the FNA was done first. Usually a PET scan is going to be like the very next thing to be done. So on this MRI, let's see, I don't know if I can use my pointer, but I see again that cystic neck mass in the right side of the neck. So on imaging, when we're looking at axials, right is left and left is right. So that's patient right side. You can tell that there is kind of isointense fluid in the middle of that cystic structure, and it's sitting just anterior to the sternocleidomastoid muscle and just posterior to the submandibular gland. Doesn't look like it's invading any of the surrounding structures. I see that node again on another slice and the next picture. I don't see any other abnormal lymph nodes, specifically in the left side of the neck.
Yeah, exactly. And obviously it's always hard whenever you can't scroll through the actual images, but neither did the radiologist. So here is the PET, and we more or less see the same thing. But perhaps one of the panelists can comment on what we see here. Is this something avid and concerning?
So there is some uptake in bilateral base of tongue area. There seems to be a little bit more prominent uptake on the right side. It might correspond to what we saw earlier on the endoscopic exam. But when you correlate the image with your MRI, you didn't see anything substantially different or abnormal in the base of tongue. So this can be just your normal uptake that we see quite frequently. And I also want to point out that MRI is a really great tool for diagnosing head and neck, base of tongue, especially, or oral tongue cancers. I don't see that very widely used. Not everybody orders MRI, but I think in this setting, you can really see the musculature of the base of tongue very well to determine whether there is a suspicious primary or not.
I'd just like to also piggyback one comment on there too. This also shows the importance of the physical examination, as the panelists earlier have sort of talked about. Because if you just look at the imaging for this patient and say, well, maybe a little bit of asymmetric uptake, but we're somewhat biased because we've got that big node on that side. If the node was on the other side, we could just as easily say, well, maybe the left side looks a little bit hot to me. But when we do the physical examination, and that's somewhat becoming a little bit of a lost art with, I feel, some of our over-reliance on imaging technologies sometimes. And now granted, imaging is great, but eyeballs and fingers are just as good sometimes and sometimes better.
Particularly for head and neck cancer, the most early stage larynx cancers are not visible on imaging, CT, MRI, or PET. And someone asked about the PET being approved with the patient's history of renal cell carcinoma. PET's usually not a great imaging tool for renal cell carcinoma. So I don't know whether the insurance would have approved it based on that diagnosis or not, but kind of excluding that history, typically, you would want a cancer diagnosis before ordering a PET.
Yeah, exactly. And actually to that point about the scope exam, that's the reason why he ended up diagnosing this patient with a base of tongue cancer. So it wasn't at all obvious on the MR, and even the PET could be swayed either way, like Dr. Wilkie said. So this diagnosis came primarily from the actual physical exam, which is good to remember. So that being said, that's actually what happened with this patient. But here's a hypothetical question, which is, let's say that we don't know, like we didn't see anything on the scope either, and the primary site was not yet identified. Would Dr. Sai perhaps touch on your approach towards what you would do in this instance?
So I have a question. So if in the case of you seeing something asymmetrical on the scope without a clear anatomic abnormality on the PET scan, but with slight asymmetry on the, without clear mass on the MRI, but with a slight asymmetry on the PET uptake on the right, would anyone be very convinced that that's the primary? Wouldn't you want to actually biopsy that area to confirm? Because many times it's just lymphoid tissue there that can also cause the PET reading and also asymmetry on the right basal tongue.
I agree with you. I didn't find that scope exam to be very impressive.
Yeah, I completely agree.
Yeah, so what actually happened was it was biopsy, but I sort of just wanted to emphasize the point that Dr. Wilkie was making on the previous one. But I guess maybe we
would do a further evaluation that would include an EUA with biopsy of the oropharyngeal areas, and if multiple sites in the EUA. It depends. If you see a intact tonsil that's suspicious, you would also consent a patient for tonsillectomy, or at least a biopsy of the lingual tonsil that's base of tongue, and also any other suspicious findings. In smokers, this is HPV positive, but in smokers or HPV negative patients, you also want to examine the larynx very carefully.
Any of the students doesn't know what an EUA is, that's an exam under anesthesia. That's usually done by ENT in the operating room. They put the patient to sleep and do a really thorough exam with lots of biopsies, sometimes bilateral tonsillectomies, to try to find basically the source of that lymph node metastasis.
Yeah, exactly. Thank you. So next poll question. So this patient was staged T1N2M0 of the base of tongue. So what would be your general algorithm of approaching this type of cancer?
That N2 come from?
That's actually a really good question. So yeah,
I didn't catch that earlier.
No, I didn't show those on the slides, but they did have bilateral neck involvement. Yeah, I'm sorry.
So you guys might have guessed, since this is a rad-onc panel, but for us, we usually are going to treat these patients with definitive chemo RT. Oh, this is a poll question. I'm sorry. Okay, good.
But yeah,
good job, guys.
Doing great.
Yeah, good job.
I think that's a great point, though. How do you normally treat these patients, and your thought process through why not a surgical resection?
I think it's defensible in some institutions, not in our practice, but in some institutions, they do surgery in both necks for small primary and not large nodal burden, especially in patients with RCC. You are concerned about giving them cytotoxic chemotherapy, and you kind of want to avoid concurrent chemo with radiation, like renal toxic chemotherapy, then people might be leaning toward surgical resection followed by radiation alone. I think it's defensible and it's not unseen in some situations. But normally in otherwise healthy patients, bilateral lymph nodes, typically in our institution, we do even either put the patient on a HPV related protocol or chemoradiation.
One other thing too, I would add, just for the medical students, it sort of brings, Dr. Seiss brings up an excellent point, because we are usually not like sort of solely responsible for these patients' care, because we as radiation oncologists work in teams. And so like we'll work very, very closely with our ENT colleagues, as well as our medical oncology colleagues, and then with radiology, pathology too, in determining the best course of care for these patients. So sometimes those tumor board discussions can, if it's a gray area where can go either way. There can be people debating their own modality, but in general, it's radiation oncology is much more of a team medicine than it is sort of individual, sort of going and off and doing their own thing.
Exactly. Thanks for those great points. And actually, multiple answers here could have been correct because of what Dr. Sai mentioned about having one kidney and the risk with platinum. So, cetuximab might actually have been a reasonable option. Though actually this patient did end up getting concurrent cysts because we did like a 24-hour creatinine clearance and figured that he'd be okay tolerating it. So here's the end too. But perhaps we can touch on these volumes and sort of what do the different lines represent when we're trying to treat these patients. Dr. Wilkie, we can ask you.
Sure. So what we're looking at is an axial and then a coronal section of a treatment planning CT scan. So for the medical students who may not know, when we design these radiation fields in this, and Dr. Sai and Henson can also weigh in on this too, but we have to map out the areas where we want to give radiation to, as well as the areas that we want to avoid. So that's called contouring. So we're identifying essentially the targets as well as our organs at risk. And in the head and neck in particular, as I tell a lot of my patients, that there's lots of important real estate up there, not to sort of diminish my colleagues who may do like prostate or some other disease sites. But if you think about all the structures, everything from the optic structures, brain, brainstem, spinal cord, it's all packed into a relatively close confines. And so when we simulate these patients, we usually will immobilize them with an aquaplast mask. So it's a thermoplastic material that we use to basically cover the patient's head and shoulders so that they can't move during treatment. And then what you see here is that these tumor areas have been delineated by the treating radiation oncologist, and then some margin added for some uncertainty in terms of the microscopic disease spread. And then if you would turn on all the contours on this, you would also see that they would have mapped out like the spinal cord, probably the oral cavity, mandible, to make sure that when we create these radiation treatment plans, we're not overdosing those structures. Because at the end of the day, this is a very curable disease, but we also want the patient's quality of life to be excellent too.
Yeah, great. Thank you. So we can move on to the second case. So for this one, we have a 59-year-old gentleman reports a 4-month history of nasal congestion and right ear discomfort. So he was placed on an antibiotics course for presumed otitis media. However, his symptoms got worse, and so he started experiencing numbness across his right cheek. He was like, that's weird. So he ended up coming in, and his PCP ordered an MRI of the head and neck. So we can begin with the poll question on this one, actually. And what cranial nerve is primarily responsible for referred inner ear pain in nasopharynx pathologies? In the meantime, if
A tough question for medical students.
yeah, but if any of the panelists want to chime in on like what these cranial nerves generally do and perhaps why, you know, we care about their involvement in like head and neck cancers.
So I'll take the first one. V2 is a branch of the trigeminal nerve and supplies sensation to the face. So V2 is like going to be the cheek temple area. I don't know if we want to like rotate. Or wait till the answers come in.
Oh yeah, I think the answers came in. I don't know if everyone sees this. It's sort of a uniform distribution. Most people think it's cranial nerve 7, which is facial, though some think it's V2 and some think it's 9.
The V7 is the facial nerve, which controls movement of the face. And in this case, I believe it's cranial nerve 9 that is affected.
Yeah, but this was a tough question, so
Yeah.
apologies for that.
And
So-
should we explain what cranial nerve 12 does?
It's the hypoglossal, so it controls the extrinsic muscles of the tongue. And so if you have a deficit in 12, the classic teaching is that the tongue will deviate to the side of the deficit. So here's the MR. Dr. Sai, what do you see on this series, and what series is this?
Yeah, so this is a T2 weighted MRI. You can see that there is a mass in the right nasopharynx extending into the parapharyngeal space. I don't think I have a pointer. So, but you can see there is the enhancement there in the parapharyngeal area, and extending anteriorly. I think it's anteriorly to the pterygoid palatine fossa a little bit, and then laterally. I don't think it's invading the pterygoid muscle yet, but you can see the clear delineation. The plane between the mass and then the muscle, and then posteriorly, without being able to scroll, I think there might be, jugular foramen, at least encroaching there, and then medially it doesn't go into go across the midline. I think the contralateral side is intact. You do see the contralateral, the eustachian tube area, and then the fossa of Rosenmuller. They are both, involved, but on the right side, you see the obliteration of both areas.
Yeah, great. And I know it's super difficult when you can't scroll, so sorry for that, but we try and make do.
Yeah.
So here's hopefully an easier one. What virus is most associated with this malignancy? Great. So most people think it's EBV, though some people thought it might be HPV. And I think those are both great because they're head and neck relevant. But yeah, perhaps Dr. Henson, you can touch on which virus probably drives this malignancy, and like where do we normally see this more like as an epidemic? Or
So the Epstein-Barr virus is associated with nasopharyngeal cancer. Sometimes classically it's associated with endemic, so more kind of Southeast Asia where you see a lot more nasopharyngeal cancer than what we see in the States. But we do see EBV associated nasopharyngeal cancer too. It's usually kind of in younger people.
Great, thanks. So we ended up getting a biopsy of the primary, and it did show EBV positive nasopharyngeal carcinoma, non-keratinizing, and undifferentiated type. So next was a PET, so similar intention as before, both for primary delineation and systemic staging. So Dr. Wilkie, can you, on these few sample slices, let us know what you think?
Sure. So basically sort of confirms what Dr. Sai basically said, a very, very nice review of that MRI scan. So we see that right-sided nasopharyngeal tumor with the increased FDG uptake. And then we also see an ipsilateral lymph node within level 2. And then we would also, particularly for nasopharynx cancers, you have to pay particular attention to like retropharyngeal nodes, and then also take a look at level 5s in the low neck, because these can go to those in a higher frequency than, say, like your mucosal squames.
So I guess we can now have some general questions, which is if we can discuss our general approach to like nasopharynx cancer, how do we normally manage it? And then do you often employ induction chemo? If so, in what context and with what approach? And then how do you or others that you know risk stratify based on EBV DNA status?
So I guess I'll go ahead. For nasopharyngeal cancers, actually for many other head and neck cancers, we first will see if the patient is eligible for any cooperative or any trials, because I think it's important to support the trials and consider patient for trials when they are eligible. But in general, suppose that there's no, okay, so suppose there is a trial available, say, for example, for NPC, there is a NRG trial that look at very personalized treatment for these patients by measuring the EBV DNA levels in the blood pre and post treatment, and then determine any additional chemo eligibility and chemo needs. So in the cases of no clinical trial in the setting, the standard approach would be chemoradiation upfront, followed by more adjuvant chemotherapy after chemoradiation. In terms of induction chemotherapy, it is not a standard in our institution, but I know it could be different because in Asia, it is very prevalent. Many patients do get induction chemotherapy to replace the adjuvant chemotherapy after chemoradiation. In our practice, we do induction chemotherapy when the disease is very, the patient has a very large burden of disease that can potentially compromise the patient's performance status or even cure if the disease is about to invade into the skull base, or if the tumor is obstructing that we don't want to wait further for radiation planning, then we would go, or if the radiation volume is too large because of disease burden, then we do the induction chemotherapy. But otherwise, we will go straight to concurrent chemoradiation. And I think I discussed about the EBV DNA on the setting of the trial, but I know in other countries, EBV DNA is actually a standard practice that they would measure pre and post treatment. But here we do it on the trial setting only.
I agree with that. And if any of the students don't know what induction chemo is, that's where induction just means you're giving something that's not the main core of the treatment, and you're doing it before whatever is the main treatment. So in this case, radiation is the backbone of treatment, and chemo can either be induction, so before radiation, concurrent, which means along with radiation, or adjuvant, which means after radiation, or it can be a combination of those things. And like Dr. Sai mentioned, there's kind of several ways of tackling it. There's not kind of one way that's known to be best. We know that surgery is not best. That's what we know. So these are usually pretty sensitive to radiation. And yeah, right now we don't really have any good tumor markers for most any head and neck cancers like we do for prostate cancer. You know, we have PSA that we can follow, and pancreatic cancer, we have CA19-9. So we're excited about the prospect of maybe having EBV to be able to monitor patients' disease response and catch recurrences earlier and things like that.
Yeah, thanks a lot for that discussion. So decision was made to treat with induction chemo followed by chemoradiation at our institution. And the reasoning for this, I believe, was because of the cranial nerve involvements, because they had numbness. So they figured they wanted to try to reduce its size, so it's potentially more manageable with the radiation fields. And so not to throw everything on Dr. Wilkie, but perhaps Dr. Henson, do you mind touching on what these volumes are in this one?
So me.
Sure, because I think Dr. Wilkie did the last one.
Oh, okay. Okay. So discuss the volumes. Okay. So in the red, it looks like we're covering our GTV, which is our gross tumor volume. And that means what we can see on this scan or on our exam. And then in the blue, that's our intermediate volume. So that's areas that we know are at risk, but we don't actually see disease there. So we're kind of treating it to a lower dose preventatively. We're coming right up to the brainstem with our volumes. So maybe we have a PTV opti or something, but that's not for this talk. And then the purple is probably what the lymph node looked like before chemo, if I had to guess, but it looks like it's responded well. And then we're covering the lymph nodes all the way down both sides of the neck on both sides, because we know that nasopharyngeal cancers have a really, really high rate of spread to lymph nodes on both sides of the neck. So we would never just treat one side. And they also tend to kind of skip down to the lower parts of the neck. So we cover all the way down to the clavicles typically. And these patients have a lot of side effects with treatment.
Yeah, thanks for covering that. And you're right. So this is the pre-induction or pre-chemo volume that we ended up taking to 6th degree. Okay, so case 3, we are on our way. It's mostly a picture, but 28-year-old gentleman, no substantial past medical history, but with significant chewing tobacco use. So Dr. Wilkie, what do you see on this photo?
Yeah, so again, shows the power of the physical examination, because if you did a CAT scan on this guy, you would probably not see anything notable, but here we see this sort of whitish colored lesion along the lateral aspect of the tongue. So other things you would want to be looking for, you'd want to sort of feel around, see if there's any depth to that, or if there's any firmness of the tongue, or sort of the floor of mouth, or the musculature of the tongue itself. You're also going to want to feel his neck to feel for any adenopathy as well. But that right there is going to merit a biopsy at some point.
Yeah, 100%. So let's see, maybe Dr. Sai, hopefully this isn't too bad of a one, but can you discuss some differential of oral tongue lesions? And then perhaps for the medical students, touch on the difference between like leukoplakia versus erythroplakia.
Yeah, so first of all, I'm surprised the patient is so young, 28. I mean, we see some young patients, but this patient is definitely on the younger side. Yeah, so the differential oral tongue lesions, there could be just oral dysplasia, like a precancerous lesion. It could be obviously squamous cell carcinoma, and there are also leukoplakia and erythroplakia, and they are both benign, but could be precursor lesions for future malignancies. And they are, the diagnosis is based on really the presentation and, the texture and coloring of the lesions. But most importantly, tissue diagnosis is very important in differentiating, not just by observing. And there are also other very more rare oral tongue lesions. There could be spindle cell or sarcoma insectoid lesions in the oral tongue and also other rare malignancies. In terms of the difference between oral tongue and basal tongue, that's actually a good question because many people, they just say tongue cancer, and it is harder to understand there's a clear distinction. So it's delineated by the circumvallate papilla. So anything anterior to that would be the oral tongue, posterior to it would be the basal tongue. And that also distinguishes the risk factors because the oral tongue cancers are almost always not associated with HPV, whereas the basal tongue, HPV is very prevalent. And then also this will also dictate how we are treating the patients because one is more surgically based, another could be radiation based.
Yeah, exactly. Thank you very much for that in-depth coverage. And so we know that our first case was an oropharynx cancer, and that one was radiation based. So this one might not be, but what would you do first?
Remember the picture of the intraoral cone from the physics book? Like scarred from it. But I feel like I would have put that as an answer choice.
Yeah, so
Is it still in there?
Was it in the con book or?
I think so. Maybe it was in the rad bio book.
Oh,
Then one of those.
I don't really remember, but most people I think got the correct answer, which is a plunge biopsy. One person is like, I know this is cancer, so we're going to go straight to surgery. So here's what the pathology came back as. It was indeed an invasive squamous cell carcinoma, moderately differentiated. And some important things to note, they said the depth of invasion is approximately 0.3 cm. And they also said no perineural invasion is present or no lymphovascular invasion is present, at least on this biopsy specimen. So perhaps Dr. Wilkie, can you mention what depth of invasion is and kind of how that differentiates from tumor thickness?
Yeah, that's a great point. And that's actually been sort of evolving certainly since I started training and then starting faculty, because we used to initially just talk about tumor thickness. And so that would imply basically from sort of top to bottom. So on your image to the left, yep, there you go, that A. And really because if you, for example, think about it, if you have like an iceberg where we're seeing the tip versus something that's really deep versus say like a verrucous carcinoma, which is something that's very shallow where it's almost like a polyp sticking off of the mucosal surfaces. And those things can have the same thickness, but they're going to behave very differently. And that's because of the invasive component. And so really what we're looking at now when we judge these is not so much how thick the tumor is, but how deep it invades. And so you take basically a plumb line and then look at the deepest portion of the tumor. And so that is going to be essentially markers on how likely it is that this is spreading to lymph nodes, and particularly from the surgeon's perspective, if we need to address the lymph nodes with a neck dissection electively.
Yeah, great, thank you. So let's see, how do you propose we treat this patient first? Okay, so I think this is actually instructive. About half said surgery and about half said radiation, probably swayed by the fact that this is a rad-onc presentation. But maybe we can touch on why radiation might not be the best approach for an oral cavity cancer first, at least.
Oral cavity cancers are usually a little bit less radiosensitive than oropharyngeal cancers or the tonsil base of tongue HPV related cancers. And additionally, radiation to the mouth is pretty morbid. So in general, surgery, especially if it's just a partial glossectomy or just a partial removal of the tongue with a reconstruction if needed, is just a lot better tolerated and more successful for the patient.
Yeah, exactly. So he underwent a right partial glossectomy and then a selective neck dissection. They took out levels 1 to 3. And so when the pathology came back, it confirmed what we knew. It was a squamous cell. And here we note that the margins are negative, as well as the lymph node that were taken out were all negative. The tumor depth invasion remained 3 millimeters. It remained that he had no PNI or LVSI. And they had sort of good margin between the tumor and the ink. So they ended up staging this patient PT1N0. And so the question is, why are neck dissections important in oral cavity cancers? And there's a second one, which is if PNI was present on the original biopsy, but not on final resection pathology, how would you approach this? And would you treat adjuvantly for that indication? This is probably like an advanced level question.
So the neck dissections are important because for oral cavity cancers, even if you don't see anything on the scan, they still have a very high risk of nodal metastases. If the lymph nodes are not adequately addressed, as we discussed before, this is a pretty radio-resistant tumor. So if you have a growth disease that is not dissected out, the recurrence can happen pretty quickly. And when they recur, the salvage can be very challenging. So this is a different situation where you really want to take out as much as the growth disease as possible before considering adjuvant treatment. If the PNI was present on the original biopsy, but not on the final resection, first of all, the PNI, perineural invasion, is one of the risk factors for local regional recurrence. And that's one of the risk factors that would make us consider adjuvant radiation after surgery. It was a punch biopsy before, and then the final resection was supposedly a larger chunk of tissue. In that setting, I think this is subject to debate, but I believe that most people in our disease management team likely wouldn't, many people wouldn't offer radiation, but I think this will be a subject of debate.
Yeah, I agree with that because just like Dr. Sai said, if this was something, I guess first thing I would do is probably just have that pathology re-reviewed. Sometimes if it comes from an outside organization or say like a community practice, and it may be called either a certain grade, or they may call some lymphovascular space invasion or perineural invasion, but those can potentially change if you have a sort of specialized head and neck pathologist reading it at a large volume center. But I also agree with Dr. Sai that if it's just in the biopsy specimen, but not in the actual main tumor specimen, it's likely of such little clinical significance that's not really going to change my mind on that standpoint.
Yeah, thanks a lot. Good. So we did not end up treating, mostly because he actually had no PNI in either of them, and because he was 28 and we did not want to give a lot of radiation toxicity to an otherwise PT1N0. But to not end super early, because we still have, like 5 minutes, here is another patient with tongue cancer who we can discuss the volumes of. So perhaps does the panel want to touch on what this splitting between the yellow and the blue is, and what is this thing?
So that thing is a bite block, I think. So in radiation, there's all sorts of devices that we can used to try to minimize, well, both to try to immobilize a patient, right? We want to make sure that we're hitting our target and avoiding all of the other important things nearby, especially in head and neck cancer, where, as was mentioned earlier, there's a lot of important things all in a really small space. And so a bite block can basically push the tongue down, away from the hard palate, to help us minimize the dose of radiation to the hard palate, and also to immobilize the tongue during treatment, because obviously the tongue can move quite a bit. I think that that yellow part is probably the half of the tongue that you're trying to spare, you know, taste and things like that, if I had to guess. And then the blue
you're
volume
correct.
is, yeah. The red is probably where the tumor was, or our best guess at that. And then the blue is the treatment volume. And it looks like on the other side of the neck, on the coronal, you're treating, I think, just level 2 or levels 2 and 3.
Yeah, exactly. So we ended up going through all the cases. Hopefully people learn from this. Now hand it back over to Jenna.
So thank you to everyone. Those were great cases. I do think that there may be a question or two that may be coming in, and we can let those come in. We do have a few more minutes, but really want to thank everyone and all the panelists. Thank you to our moderator, JP, and to our coordinator, Nav Sandhu. Please make sure to try and do the post survey. It just takes a few minutes, and we do utilize those surveys and try and improve on our sessions. And we give out Amazon gift cards. So it's a quick 5 minutes for a possible Amazon gift card. Next slide. You can always contact us. You can send an email, and then you can look at our website. Next slide. ACF.
Oh, go ahead. Oh, okay. Yeah, and so this is the website. There's lots of information on the website. You can find faculty, you can find mentors, you can see which programs are offering which types of rotations, specifically virtual rotations, and you can certainly contact any of us. Next slide. And this is our next session, which will be awesome because it's GYN cancers. And it's going to be featuring Dr. Ann Morris from West Virginia, Dr. Scott Glazer from City of Hope in LA, and Dr. Samuel Markram from UAB in Alabama. So lots to look forward to. And definitely complete those surveys. Who doesn't want an Amazon gift card? Oh, and then, yes, it looks like the panelists are going to allow you to email them too. Oh, here comes the question. So what is the role of emerging radiation modalities, such as photodynamic therapy or laser immunotherapy? Do you see the role of these treatment methods changing in the future? Since we have a few minutes, does anyone want to tackle this question?
You know, there's trials looking at those things. We don't currently have any open, so I can't speak to it very intelligently. It's probably a ways off. I think it's all pretty early in the pipeline. The others might have insider knowledge.
I would agree with that. So like photodynamic therapy, it's been used, like I've seen it used as sort of salvage therapies occasionally. Like for example, like recurrent esophageal cancers and some larynx cancers as well. I've been somewhat less impressed with it because essentially you just don't have very much penetration depth. And so it'll make the surface tumor go away and then they just recur deeper to that. I would say probably the more interesting topic, and something we sort of didn't talk about, is looking at like dose de-escalation or treatment de-escalation management strategies, particularly for some of these P16 and HPV positive cancers, because we are seeing those a lot more commonly in younger patients.
Great, thank you. Final reminder, fill out your surveys, and thank you, everybody. Have a great afternoon.